Wisconsin and Minnesota? Come on, you mix us up.
Especially since I lived in Michigan.
That's trouble. Well, good morning. It's good to be back. Appreciate us having an invitation to be here today. So as Gary said, my name is Peter Carlson from North Memorial in Minnesota. And some goals for today would be to learn about our program a bit. And Dr. Tangy spoke on us yesterday. So I may duplicate some of what he said, but hopefully we can talk specifically about the grocery store. For some reason I get nervous with small crowds, so has anybody got like a British joke? Please. No. NHS, thanks. Well, we woke up to Tom Price, so. But again, so we're going to talk a little bit about how the ground break is coming up here in April, and we'll be working in the store come December. So we've already launched into a couple of different brick and mortars, so grocery store will be our third area of focus. Group, I changed yesterday. I was wearing the same outfit as this picture. I decided to switch it up a little bit. And this is, zooming in, I'm curious to see where it lands. So best group of people I could imagine getting into management with. This is 250 years of intellectual property, a lot of curiosity and a lot of energy. Paramedics are curious folks by nature and really want to quit just calling and hauling. And so this is giving this group of folks an opportunity to be a part of that solution. A little bit about us. We are covering a county of about 600 square miles. 50 of that is lakes and rivers. If you've ever been to Minnesota, you know that we're big fans of our lakes. If you haven't, you should come. We've got about 1.5 million residents in that 600 square mile area. Our system has 18 clinics, a trauma center, and then our paramedic system is pretty diverse in the sense that we cover air, PCP, ICP, ACP, and CP. So we've got kind of the full spectrum of services. What's unique about our community paramedics, though, is that we don't actually report up through our ambulance or paramedic structure. Instead, we work with primary care or general practitioners. So that's our structure. And we have the opportunity to work with 2 different hospitals, both within our system. So the way that we go out on a daily and weekly basis is through 3 different approaches. We have transitions, which in the States, we do have to do a lot of work with payers in order to really sustain this. So you'll see a little bit about how we're working with Blue Cross Blue Shield on some of their transitioning hospital-to-home populations. Likewise, we do some chronic disease management. I think a lot of programs, including ours, dabbled in heart failure, asthma, COPD, other areas. We've found that while it's possible to focus using data analytics, it tends to be patients dealing with multiple comorbidities, so it's very difficult to focus in on a single track. We saw yesterday a wonderful program in Indiana that using zone pathways, you can do a lot of work with heart failure. So we've done similar things with pediatric asthma, which we'll talk about later today. The piece that we're really going to touch on today with the grocery store is with our third area of coverage, which is community engagement. So this isn't going to work for us in our area if we're not engaged in the community. We end up with a lot of dependency. Our community paramedics are, as a manager, I'm making sure that they understand boundaries. If you're done with your shift, please be done with your shift. There's a lot of folks taking call on the weekends and on the nights. And that's a great problem to have, is that people care too much, but we also want to make sure others in the community are working as a support structure for our patients. So show of hands, how many people have been to the GP in the last 5 days? How many people have been to the grocery store in the last 5 days? Jesus, does anyone grocery shop? All right, tough crowd. So our goal by getting into the population that we're going to get into is to decrease windshield time. First and foremost, we have to really be operationally efficient. At the end of the day right now, we're not being reimbursed at a rate that is sustainable to keep this program going. We need to find creative ways to make sure that we're concentrating on populations that we're reimbursed for. This is just a snapshot of 2 months worth of visits and just showing the coverage. And I apologize, it shows up in kilometers. For some reason, if you Google anything here, it goes to kilometers. But I learned that you have miles per hour in England. Somehow I didn't know that in my whole life. Neither did Google, it turns out, if you look into their forum. So this is about 50-mile stretch on some of our outliers, in terms of the concentration is really within about 20 miles that our groups are moving, or our individuals rather. And our CP works solo in a vehicle by themselves. And then we actually have to break it down in this fashion as well. We need to see where our payers are. So this is all of this is 2000, I think. This is a couple months worth of data. We do about 100 visits a week. Our staff are out serving about 160 hours per week. So again, when we look at this, we're thinking, where are the more dense populations that we know today in Minnesota due to reimbursement, i.e. what's called Medicaid, we're able to receive payment for, and we're really able to drill down into this kind of corridor, which is referred to Minneapolis, Brooklyn Center, Brooklyn Park. So when people say they're from Minneapolis, they're probably not. They're probably from one of our 100 suburbs. Minneapolis is actually fairly small, less than 500,000 residents. So again, what we did to decrease some of our windshield time was we tried to create zones so that if a staff member is coming on at the start of their day, they know they're covering 2 to 3 clinics, and that gives them 12, maybe 15 doctors and PAs or physician assistants and nurse practitioners to interact with. Likewise, 3 days a week, they're going to get on and huddle as a care team in the mornings on the phone to discuss what the plan for the day is. And then obviously a lot of outreach to Dr. Tangi as well. So the other things that we did was, the second bullet point, what this really means is that, again, within the insurance industry, which is very hard to not talk about, especially when we all woke up to Tom Price being announced as Health and Human Services leader this morning, for those of us that were trying to keep an eye on that. So insurance kind of does drive everything. And so as companies push patients to certain systems, they attribute to those systems. Likewise, the community paramedics are trying to think, how do we help our system become more efficient? And so what we try to do is go out and visit our patients and empanel them. So really with the grocery store, this gives us, again, a concentrated physical address to work on, getting more folks through one area. So we'll talk later about chemical dependency, the work we've done with the mental health clubhouse, and then today we'll focus on the North Market. And its roots are within a larger project funded by a medical company, Medtronic, working with a Health Rise grant in multiple countries. All the monies that came into the US came to 3 sites in Minnesota, and they're all using community paramedics and community health workers. So a very exciting opportunity to work together as emerging professions, and ultimately that's our goal, is to end up having the CHW along with the community paramedic at the grocery store. Just a more macro view, and by the way, Minnesota is here, Canada is here. We are not building any walls at all. Yet, yes. Now the Dakotas, on the other hand. So 6.5 million children, which is in white, I apologize, in the bottom. It's no wonder that we have our work cut out for us. We have work to do, and we're just trying to help in our small area. So here's just a corner street on the north side. This is an area where for 10 years I worked as a paramedic, and so the other folks in the picture earlier, a lot of them have worked this area for upwards 40 years. They have a lot of connection, while it is not primarily people that look like us living in this neighborhood. It's an honor to be able to work with the community and to really identify the fact that there is a food issue, especially secondary to transportation. So this just shows that of the 70,000 residents in this single zip code, that convenience stores and processed foods are bountiful. No issue getting some crap. But when it comes time to get some good food and then learn how to cook it, once you've gotten home, it's a little more of a struggle. So our goal is to come up kind of into the center of this picture and actually put the grocery store is being built by Pillsbury United, and then we're helping to staff it along with pharmacy and community paramedic. So again, where we're dealing, this is North Minneapolis in the white. I'm not sure if you can read that on the left. Versus total city data in Minneapolis. The life expectancy alone is difficult. And our hospital is situated right in the center of this. So as we do a community needs assessment, it's quite obvious every 3 years that we have to do more. We have to be there for the community in a different way other than just call, haul, kind of treat, back to the street. And so as a system, we've been improving that approach significantly, and the community paramedic has been a really big help to that. So as we look at the system approach, again, healthcare perspective is what we're trying to kind of bring in and make sure that as folks come in, they don't identify the grocery store and the community paramedic that's there as a substitute for the clinic, but rather it's complementary, and it's how to adhere to a care plan that's been created by the community health worker along with the patient and ultimately their family. So, and also another motivator for this was the concentration where we worked at a chemical dependency post for 16 hours a week allows us to see upwards, 2 patients per hour, which typically we're averaging about 112 minutes a visit right now with drive time and everything else. So it's a great way to reduce some of that. Whereas Pillsbury, their community health workers are quite new to their role, they've been living in the community for many years, but they need a little extra assistance. So the excitement to this project is that we'll be able to have those 2 people really partnered and working in tandem at the store and be able to increase some of their experience while we're improving our efficiencies. So I think we've been hearing this over the last day. Very excited by every group that I've listened to. I mean, this kind of gives some more wind to the sails. I've been a part of this project for 5 years. A handful of us showed interest in the beginning of community paramedicine at our company, knowing that it's been around for quite some time with different names and different forms. But occasionally it gets tiring, so it's really nice to come be around a group like this and kind of get remotivated. And I think that needing a new approach is supported in this room. So the disruption that we're trying to do with this is to really integrate food where you just probably, as you go to the grocery store, aren't really thinking a lot about disease because you're probably healthy by the looks of almost everyone in this room. It's different for different communities, and I think when we polled areas to find out what is grocery shopping, what is health, what does food mean to you, there's a lot more identification with history of, food means to me chitlings from the South, as we heard yesterday. Food, means to me, come together and let's fry and let's kind of have a good time. And so it's balance, and it's the community paramedic core skill set, which at the end of this, we'll look a little bit at our documentation. Our staff are blessed enough to be right in the electronic health records, so we can kind of look at the trail leading up, deal with and help with the patient, really put those words to action that the hospital told them. At our hospital, an average of 28 people come into contact with every patient every day they're there. That's a lot of people. They're hearing a lot of messages. So really we're just helping to try to orchestrate that. And again, the physical layout of the grocery store, which is a couple slides away, really allows for that conversation to happen. So how we identified all those points of how many people talk to you at the hospital, what message are you given at the clinic that is difficult to apply in life, is by doing human-centered design. And so we worked with a firm out of Minneapolis called B-Swing to do a lot of activities and go out into the community and be a part of the interviews with the population and make sure that at the end of the day, this store is built not by us in a way that we think the community would benefit from, but in a way that the community decides to build it and ultimately staff it as well. So what we heard from the community was very exciting. I think there's a lot of different, very diverse community, and so it's a wonderful opportunity to hear the differences of what healthcare delivery means to a Hmong resident versus Native American versus African American versus, it's a great community to go in and learn a lot from. So for our community paramedics, this is not intended to be a break in a busy day, but really complement all the energy and work that they've done. posted in this neighborhood for years in the ambulance, going to the shootings, going to the stabbings, going to the same kind of calls, and now it's going to a grocery store. And believe me, there's like we're doing what, at first, like from staff, especially from our advanced care paramedics that maybe aren't a part of our community paramedic program. And then the more they hear, the more engagement and interest and buy-in there typically is. So what we're hoping to do is just offering, it ended up being 1,500 square feet, so not a lot of space in this lower left. And we ended up giving part of it to the pharmacy, and then we're gonna have a classroom and a lab so that our goal is to teach group cooking. We're working with other large manufacturers to offer Pyrex and Tupperware and things that we can end up doing meal cook, prep, take home. The way in which we're going to engage with patients is again through both data analytics, which we're privy to through our measurement and reporting system and through our claims coming out of our state. And also, folks can sign up themselves through social media. And the plan is to actually send the community health worker and community paramedic into the home for patients who maybe need to have a little more trust built on the subject versus just come to our grocery store and get healthy. And so the goal is to get into the home, offer some foods, make the second appointment for this area and be able to start building a rapport and complement that with an app that allows us to kind of remain connected. But again, to get them into primary care, and it doesn't need to be our system's primary care. There's a couple of opportunities in what are called federally qualified healthcare homes in this area. So we're okay working with wherever they want to be or wherever they've been. Just some of what we're hoping to provide, kind of list of services, and again, I won't read them, but feel free to ask any questions. And this will be a living document. We're just going to kind of start with what we're anticipating as a need as a result of the questions we've asked and the discussions we've had in the community. But I would imagine this will change. And there's definitely, a hope for a telehealth component. It's interesting because it's less than 1 mile from a clinic and less than 1.5 miles from a level 1 trauma center. But it gives an opportunity to have the patient connecting with a higher level provider at times where it goes beyond this set of needs, or kind of as we learn and ramp up, it could be a great way to have some support while we're there. These are really busy, so I apologize, but I think I added them yesterday as I've heard the theme throughout our discussions here, really revolving around data. We're happy from our group to offer anything we have. We use what's called Epic electronic health records, and we've built a fairly good module for the work that we do. And then anything in red, this is just an example where as we build our documentation, we're able to, it's cumbersome, but we're able to get a report at the end of the day so that anything in here that's discrete data we can actually pull out and kind of keep, as a living document as well, so we can try and improve the work we're doing. But I think the questions that we're asking here are exciting. I've been on my share of 911 calls, or I must have said 999 calls, where you just literally got to a point in my career as a paramedic where I would say, anybody else in the house want to go? We got a big bus outside, let's go. And people, okay, yeah, I'll go. Suddenly you'd have 5 people in your ambulance. Community members want more than that, and they want to help. They want help in this fragmented care system that we've offered them. And it doesn't sound that much different no matter where you are in the world. I think folks struggle with healthcare. Our community paramedics at North Memorial are trying very hard to just help pilot that care with the patient so that ultimately we don't have to stay in the relationship longer than necessary, and ultimately that they end up back in their community. And by getting there, or in order to get there, we have to ask interesting questions that we haven't normally asked, and then develop a plan. So every intake documentation that we do has an assessment and a plan where we're just anticipating how many visits we're going to have with an individual, which in the last presentation we saw the wound, and obviously there's scenarios similar to that in our system where we've done I don't know, 12, 13,000 visits now, and average out about 6 visits a patient. And that's a lot of ones bringing down, you know, a couple of 200s where we've seen a patient for wound care. And it makes all the difference to that individual. And where we've tried to quantify things like that is by saying that individual was slated for a amputation, and that DRG was like $100,000. Okay, that's just money. I mean, to this gentleman, to this patient, it was a leg. And so it's been interesting for our group to stay with people like that, and now 2 years later, we've got his wounds back to a stage 2, 1, comfortable to the point where his leg's definitely not going anywhere, he's content. But that very first visit, what do? You know, I mean, it's very difficult sometimes for our staff to document and say, yep, we're gonna see this patient for 7 weeks, 10 visits. And that, again, to tie that back to the grocery store, what we're hoping is that we're seeing how other providers are kind of putting us onto this longitudinal care plan, and that'll help us make a little more sense of where we're fitting into their life. So care plan, care plan, care plan. That 5th up from the bottom, I think that's the biggest thing that we try and to focus on, whether it's amputation that you're trying to avoid, or you just want to get to your granddaughter's wedding in 6 months, but you broke your hip. Whatever the goal may be, we just focus on the plan. So that is the extent of it. So the grocery store work will look very similar to what we're doing, except rather than being in a home, you'll be in a grocery store. And we'll see. Hopefully we can come back at some point and share what that experience has been like. And it's similar to what we'll talk about this afternoon with Turning Point and Vale Place. So any questions?